Hello, everybody, and welcome to today's webinar, where we'll discuss how the Pennsylvania Mountains Healthcare Alliance applied a revenue management technology adoption model to achieve success. So with that, I'd like to introduce today's speakers. We have with us Jonathan Wick, the Vice President of Health Insights at FinThrive, and Nicole Clausen, the Vice President of Revenue Cycle at the Pennsylvania Mountains Healthcare Alliance. Jonathan and Nicole, thank you so much again for being here with us today. I'll go ahead and turn the floor over to you to get us started.
Thank you. The agenda for today will be a market update, our PMHA approach, the RCM TAM, the PMHA application, and also Q&A. Jonathan, do we have you back?
While we wait for John to hop back in, this is Dale from the Becker's team. We just wanted to pose a really quick question to our audience members today to kind of help inform today's discussion. So audience members, look to your slide. You should see a polling question about what number of RCM systems are in place at your organization. So I want to get just a little bit of crowd work and understand kind of where our audience is coming from. So please take a moment to fill in. You can just click on your screen there, whether it's A, less than 5, B, 6 to 10, C, 11 to 15, D, or greater than 15, or E, if you don't know. So please take just a moment to fill that out, and we'll get John back in here in just a second. And a few responses in here. Again, our options are regarding what number of RCM systems are in place at your organization, whether that's in the less than 5 range, all the way up to greater than 15. Looks like we have quite a few responses in here, so I'll go ahead and close the poll. And it looks like we're at 44% have less than 5, and then all the way down to 60% have 6 to 10. No respondents on today had greater than 15, and about a third of folks actually don't know at the moment. So thank you for hopping in and for kind of giving us a little context here. Nicole, can I turn it back over to you to take over here?
Sure. While we wait for Jonathan, I am going to skip us right ahead to talk a little bit about Pennsylvania Mountains Healthcare Alliance, and we can come back to Jonathan's slides. So my name is Nicole Clausen, Vice President of Finance and Revenue Cycle for PMHA, or Pennsylvania Mountains Healthcare Alliance. Just a little bit about our organization and myself at PMHA. So PMHA is a collaborative network of independent or mostly independent community hospitals. We are members, but we can act like a larger hospital system by way of purchase power, sharing staff, and best practice and standardization. Our mission is to enhance the ability of its member hospitals to provide patient-centered, community-based care and to maintain their status as independent community hospitals. We have maximized revenue and minimized cost for our members, and making our hospitals efficiently operating providers and contributors to the respective communities that our hospitals reside in. Just a little bit about a quote I've had before. I'm really excited about AI and how we're going to incorporate bots, and we're going to do that with FinThrive. Jonathan, I'm going to, now that you're back on.
Yeah, sorry about that.
That's okay. We did the poll, and so okay, if you want to go back to your slides, we can.
Sure, I'll hop back and go through them real quickly. Sorry about that, everyone. I think we all still kind of live in a world of internet. But you guys can hear me okay now, and let me know if you can't. Yeah, so just Kaufman Hall really quick. I want to kind of set the stage for the market. You know, we've had probably one of the more challenging years in 2022. Most hospitals, including I'm sure Nicole's and PMHAs, are showing some positive margins, but 2022 with the affiliated systems and others has definitely been a deficit that we've had to climb out of. Some highlights from that report really surrounded the stabilization, even in terms of length of stay, expenses, especially labor, and I would argue supply expense are starting to finally stabilize. We're starting to see also some capital efforts start to come around. And what Nicole and I are going to talk to you today about really is going to surround how do you strategically plan using this RCM TAM adoption model framework as you move forward. And we'll walk through, how that's going to impact, some of these headwinds that you're seeing too. Volumes have been really, really volatile. I don't think you're going to see visit volumes at the hospital level be what they were pre-COVID. I think you're going to see some sort of deficit in the single digits. Staffing continues to be a problem both on the clinical and the finance side. Denials are triple right now too, and I think this is probably one of the more alarming stats you'll hear today. This data comes from Clarivate HBI, and they typically, we all know that have been in the industry, they've ran about 1% or so. If you're a best practicing hospital, that's kind of been your benchmark of write-offs at the end of the years. You're going to lose about a 1% back to the payers. That number's running triple right now, almost quadruple. It's starting to dome out a little bit, but the payers are certainly playing some hardball. The last thing I wanted to point out before we get into kind of what Nicole's organization is doing is just, we took a survey. There's a QR code here at the top if you want more detail that really talks through the transformational kind of strategic priorities or areas of interest that hospitals have. We surveyed 86 organizations, and they came up with these top 4 areas: increased revenue, reduce cost, improve the patient experience, and finally manage staffing shortages. And I think if you asked any executive, even Nicole and others, they're going to go, yep, those are our 4. That's what we're trying to work on as we move forward. And they were there when I was running my revenue cycle as well. So it's certainly validating the need to be where we're at. I'll turn it back to you, Nicole, and sorry to join a little late.
Thanks, Jonathan.
You bet. I'll get you to that slide. There you go.
All right, thank you. So just a little bit back to PMHA, Pennsylvania Mountains Healthcare Alliance, my organization. Little at a glance facts. We have 12 members and 14 facilities. So what that means is we have 12 member hospitals and 14 facilities that are currently using some or a part of our revenue cycle products. Collaboratively and collectively, our net patient revenue is 1.1 billion with combined staff beds at a little over 1,000. So on the right, you will see just a snapshot of locations. Primarily, you will see we are in Western Pennsylvania. We do have a couple organization facilities on the east side of Pennsylvania, as well as a few in Western New York. Some of our challenges, Jonathan had some great slides, same thing at the PMHA member hospital level. And I always say these challenges are consistent. It doesn't matter if you're a big facility, a big health system, or if you're a community independent hospital, we all have the same problems. And specific to us at PMHA, we looked at first with our technology and our current vendors, and we had multiple. It was hard to piece it all together. We had the lack of analytics. We have a lot of manual as we now are implementing, but we aren't fully implemented yet. We still have a lot of manual reporting, and that's what we needed to get away from. How could we let the system do more of the work? How could we automate the work and get our KPIs out there as well as the workload? And workforce. We hear a lot about clinical staffing shortages, but on the revenue cycle, there's problems finding talent there as well. And that's at our level. Even though a lot of our hospitals are close to Buffalo and Pittsburgh, we still have trouble finding talent, and so do they in the bigger cities. So how do we become more efficient? By putting in these systems and these bolt-on technology efforts, we aren't looking to reduce staff because we can't find them anyway. We just want to do things more efficiently with the staff that we have. And investing in technology was how we were going to do that. We had a system strategy task force that went over a year long, including multiple CFOs from our member hospitals, our own PMHA team, and other members. And what our goal was is we need to stay ahead of the changes. Healthcare is ever changing, and we know that we need to embrace that culture of innovation that'll help us get through all those changes and identify them as quickly as possible. We have clean data in the system. We base everything we do on standardization and best practice, but there's things that we couldn't control with all these multiple vendors and piecing it all together. So we want to have that reduction in denials and clean claims going out the door. And additionally, we want to make for sure everyone has access to the information. We don't just work it in revenue cycle. We want our revenue producing clinical areas to be all in as well. We want them to use the systems. They need to own their departments and the revenue that they produce. We aren't in an era anymore where we can count volume, and that doesn't do the trick anymore. We have to make for sure that we get paid for the services we provide. So, and then automation, it's huge for us within the PMHA network.
Cool. Thank you, Nicole. We're going to jump into another poll question here. What is a primary focus and revenue cycle for you? And we'll open up that survey and have folks start to fill it out here. And, you have to pick one. That's why I use the word primary in there. I used to tell my CFO, I've got one fire truck and one hose. I could go from fire to fire, but I would love to work on all of these things. But if you had to work on, one of these, or what is your major priority, I'd be interested to understand, the thing that you're going to tackle in January of next year, or even that you're tackling now as you're walking through. These are common issues in revenue cycle. I think the patient's the new payer, and understanding the loyalty there are the first two elements. Prior authorization always, and denial seems to be, I call it the D word in the industry, that always seems to drive some level of consternation at most organizations. The regulations that are out there with NSA and transparency. I attended an HFMA webinar yesterday that was very, very good from Sean Stacks and others talking through the new regs and when they're getting enforced with the new OPS, PPS rules. And then finally, revenue integrity and payer reimbursement. Looks like we've got about a 30 or so answering here, so we'll pop on over and see a good swath. I am actually very pleased to see revenue integrity and payer reimbursement be the number one issue there, kind of definitively, and outpacing prior auth. That is exactly a lot of what Nicole and PMHA is focused on. It's a lot of what FinThrive's focused on, all of these, but I'm hearing in the market, and that's very validating, that getting paid what you're owed for the care that you've provided is a number one priority right now at many, many organizations to understand where we're at. So that's very comforting to see that happen. Let's talk a little bit about what Nicole and I shared. So I think as you look at vendors, and I like to call them partners over vendors. I was a chief revenue officer at a hospital for a very long time. I started as a transporter. I had 26 different partners working in my revenue cycle platform as we were managing our bills and our intake and our follow-up and cash. I think those are being very closely evaluated, and Nicole shared at a high level kind of where they've gone in their end-to-end or platform evaluation journey in terms of PMHA and what they're doing for their members. And it's a lot of criticality is happening now. I would argue a lot of measurement. And that's good. I think every organization that's listening on the phone right now should absolutely be holding their partners and their vendors accountable to what's being delivered. And there should be a critical look at that, because there aren't a lot of capital dollars sitting on the fence. And these are questions that when you're doing that, I think come to mind. What is outside of my core model? You may be operating on one instance of Epic or Meditech or Oracle Cerner or others, or you may have a similar one. You may have multiples or hybrids going across. I've talked to several health systems where they've got multiple EHRs out there from different platforms. They're trying to get them all to one. What technology is in place? What has been bolted on from a third party? And how effective is that? What am I paying for it? How many do I really need? I think these are tough questions to ask, other than, Nicole and I getting on the phone and maybe asking each other has been kind of the method du jour lately. And what we're going to talk about today really is this model and walking through how to fix that. And I think as you look at models, this survey I really liked. It said, hey, if we've got all these problems that Nicole and I have talked about, this is 205 CFOs, how are you fixing them? Or what's your kind of approach? And I like this. The first was, 29% said to find a partner. Another about quarter or 26% said to adopt new technology or software to get there. And we'll talk a lot about that today. And then another 24%, which I really like, is kind of slicing the fat off or removing redundancy. I've been in hospitals where they've got 3 eligibility vendors. That's not needed, frankly. You need to run eligibility multiple times, but you don't need multiple vendors to do it. And in my opinion, and if you look at all of those, they really do come down to your talent, your people, and then really partnering with a trusted advisor in the market that's got technology that can get you to the finish line. We're going to transition now to this revenue cycle management technology adoption model. And there's a QR code there, and you're welcome to scan it. And you can multitask while Nicole and I are presenting, or you guys will have these slides. You can go there later, but this will bring you to a link that actually talks about the model from a gentleman called Jeff Becker, wicked brilliant guy that works at FinThrive that has helped really bring this home and put his heart and soul into it, along with many others, and also talks through the assessment and how to get there. I'm going to go over at a high level pretty rapidly because I want to get to Nicole's approach on it and what PMHA has done. But the hypothesis really had about 84 or 6 organizations initially kind of talk about what is your revenue cycle management footprint? What does that look like? And we wanted to make sure that it was an accurate swath of the industry. We wanted to have Epic, Oracle, Cerner, Meditech hospitals represented. We wanted different roles. We wanted different net patient service revenue sizes, different bed sizes, so that we can understand and make sure that the validity of this data is going through. And it really measured 2 things. I think the model sometimes can be a little bit overwhelming when you're looking at it. It measured, first and foremost, is the technology that's out there valuable and mission critical? And we took those ones that were scored as mission critical and high value and left them in the model. And then we removed anything under moderate, low value because we felt that might have been noise. And then the technology was kind of based into stages. If that is a mission critical or high value solution, if it's something that most folks are probably needing or using that have to have, it's kind of the must-have things, let's put that towards the left of the model. And those are things like eligibility and claims and maybe some of the registration and intake types of screens. Then you start getting into prior auth or machine learning coding and those types of things as you move to the right side of the model. We put those into 5 stages. And then the other thing that we measured, so there were 2 things that we measured, is the technology valuable? And then is the technology in place? And so that's what you're seeing here in this spread on the right is, do you have this technology? Yes, you think it's valuable and a must-have, but is it in place at your organization or not? And that allowed us to kind of come up with this maturity spectrum. Are you a stage 1, a stage 3? You may remember meaningful use, and when HIMSS had what was called an EMR or MRAM adoption model strategy that had stage 1 through 7, and it had things like computerized physician order entry and others that allowed an organization to understand in their meaningful use journey where they were. This model is very similar in its approach in that it's looking at what technology do you have in place that's highly valuable or must have, and do you have it or not, and where along that spectrum do you need to fit? We also took it, which I really like, and looked at, does it matter? And a question you should ask often if you're in revenue cycle, and I know Nicole will agree with this because she's a brilliant lady, is so what? Like, so what, Jonathan? We've got all this technology. Is it moving the needle? Is it driving value in your organization? And we measured these 6 KPIs, and we did see that. Folks that were on the left end of the spectrum that maybe had a low level of adoption across all of the technology or had pretty elementary or basic level type things did not have the financial performance of those that were a very mature, high technology footprint. Makes sense, right? If an organization has lots of technology looking to capture revenue and automate where things are at, they should drive higher financial yield in their organization. And we saw that across these 6 categories of point of service collections, denials, AR days. We have very detailed data on this as well. If you need to follow up with me later, so we can help you understand where you're moving. So the model broke out into these 5 stages. This is probably your first introduction to it if you haven't seen it. I saw some notes in there from Crow, and I think this is a little bit different than Crow in that it gets pretty granular in terms of understanding, one, what technology is in place and is that high valued by the industry and a must-have, and then secondarily, does your organization specifically have it? And if you don't, how far of a journey? Are you at the bottom of the hill or the top of the hill or in the middle of the hill as you move forward? About 43% of the market was in that stage 1 per the survey. About a third were in 2, about 1 in 10 were in 3, 1 in 10 were in 4, and then stage 5 is very aspirational. That, is that top peak, if you will. And if you look at some of the things in there, there's some shading here as well. That kind of darker green are those mission critical or must-have type technologies, and then the high value ones are that lighter shade of lime. But prior authorization, at least having that being monitored. Most folks have a manual process for prior auth that's supplemented by some level of technology, but actually saying, hey, this one's going to deny if you don't do something, or this procedure changed, you need to change the auth. That's what that item in the 4th or 3rd bullet there on the right mentions. It's kind of a real-time type thing. Automated appeals, end-to-end RCM analytics, which Nicole will talk about here in a minute. Those are those stage 5 things. This is Nicole's responses from PMHA and her team. And Nicole, I'm going to ask you some questions here in a minute, but you can kind of see what this looks and feels like from an organizational level, right? So this is, the green and lighter green coloring, as I mentioned, and then you're going down the list. It's kind of like a grocery list. Do you got it or not? You're checking a box. So Nicole, just some questions. When you got this, what were some of your initial impressions? One, I guess, about the scope of the model, and then where things kind of fell left to right. Did you have some initial impressions there?
Well, I think first, just looking at the different stages, I think FinThrive did a very good job at laying this out. And, I'm one that always likes a challenge, right? So do I want to get to stage 5 someday? Absolutely. And just like you said, if, as we go through and pick off what's valuable to us right now, I think this will only grow. But, as far as mission critical versus high value, I think you see there's high value in everything, but the mission critical are things we have to have. And I'm sure you're going to go over this more, but even some of our mission criticals, we aren't doing just yet. Not to say that's not a plan to roll it out in the future.
Good. As you walk through the model, we also do an assessment of where you are on those KPIs, which I think is great. One of my biggest peeves in the market is there aren't, kind of benchmarks available that are easily used or published in an apples to apples format as it relates to technology. You can go out there and look at map keys. You can look at HBI Clarivate. You can look at NAM. You can look at lots of different metrics, but from an industry best practice performance standpoint, based off the survey of these 100 plus hospitals that we have and health systems, and it really starts to fan out in terms of how are you doing against everybody else in the stage, and then also as you advance through the stages, which I think is great. Phenomenal performance here. First of all, Nicole, you nailed a lot of these at PMHA, which I thought was great. You're right in the range of benchmark performance for point of service collections. Clean claim rate, as you'll talk about and you've talked about with Becker's and others, is certainly an opportunity for you. Your AR days are at industry best practice. Your AR over 90 is a little high as well. But what are some impressions with these numbers? Are these relevant to your organization and others, do you feel? And then do you like the line of sight with these, or do you see opportunity? What's your thoughts on KPIs?
I definitely think we have opportunity. And even though, we've checked some of the boxes, I think we can continue to be better. And that's what I kind of want to keep challenging our member hospitals within PMHA. And exactly why we wanted this technology is, we want better clean claim rates. We don't want our aging over 90 to be where it is today. And we want that cash on hand to be a better value as well.
Good. As you progress through the model, it starts to do one of the coolest things, I think. As you know, the cog of revenue cycle stops for no one. And it's got many, many gears, many moving parts, and anything that has anything to do with cash or non-payment is always patient access's fault, and then it's billing's fault, and then it's managed care's fault. And what I love about this is a footprint, a really nice diagram to look at. And I know it can look like a jar of jelly beans if you kind of squint at it, but I'm going to walk you through it. On the left, there are the business processes that happen within revenue cycle, which I love. So your patient intake and acquisition, your scheduling, your registration, that's the blocking and tackling that every health system has to do to get patients from hello, how are you, to a zero balance bill, all the way down to revenue recovery and cash there, as you can see. And then as you progress left to right, you can see like what are pieces of technology that are required per the model that we showed you to effectuate and drive value for that business process in your organization. And then they're color coded. That darker green is, you got this, you're good. To Nicole's point, there's always room for improvement. Maybe you're kind of using it. I'll give you an example. I was in a hospital on the West Coast, and they're running estimates for every patient, giving them to them electronically. Awesome process. They're not asking for money at the front desk. So they're making patients aware of their point of service collections for when the billing cycle happens later, but they aren't actively asking for money at registration. And I think that's a missed opportunity. That may be green, that dark green on here, but it's not. It might have some opportunity in terms of both people process and technology. The orange are those mission criticals, and then those salmon or light pink are the high value areas. So this allows PMHA and Nicole to kind of look at this and go, okay, which one of these do we want to focus on? Because this is a lot to look at overall. And at Nicole's organization, we'll go to you here in a second, Nicole. You are focusing in some really interesting, and I would argue probably high risk areas, which are good. You know that. You're focusing on scheduling and pre-reg. You want to make sure financial clearance is right at the start so that bills go downstream correctly and you're not cleaning up a mess that may have happened up front. Claims and charges need to be captured to make sure your bills look right. And then your appeals. Do you have anything to add here? Why were these three areas kind of important to you?
Well, I think when you talk about scheduling or pre-reg, we want to get everything that we can possibly get right before the patient even walks in the door. So that's just number one top. Charge capture, we want to make for sure that we're capturing what's done to the patients. And that's a big area of risk. A lot of times, we do try to automate using our operating systems and charge upon completion or everywhere we can. But there are things that have to be soft coded or manually applied. And
Right.
it just leaves room for opportunity. And then appeal follow-up, everybody talked about it in the poll. That was their top, and you've talked about it. The denials are out of control, and
Right.
we have to be able to be on top of that and stay ahead of it as much as possible.
Good. Well put. And then we take that level and go, okay, that's great. We all have lived in revenue cycle, at least most of us on the phone. We have no time, no money, and no staff. That's a fact all of you have. And so spreading this out over time and saying, okay, look, let's strategically look at this over the next, 2 to 3 fiscal years. Departments like IT, the PMO, I would argue the CFO, even this patient experience clinical teams like understanding what is our process improvement, technology-enabled roadmap going to look like for revenue cycle over the next 2 to 3 years. And even this one goes to 4 to 6 years, which I think is great. And it talks, okay, we're going to focus first on ID and address, charity care screening, making sure folks have the right financial class assigned, virtual intake, making sure folks can onboard to our services and streamline registration, contract management. All of those things are key. And the little orange circle that's there are things that PMHA is prioritizing over the next year and a half. And that's awesome. And I think it's great that you can kind of look at this. And this one of all of the visuals that we have is one of my absolute favorites because it allows just a one pager to go, hey, this is what we're working on. It's a great teaching tool. I think also it's a great team tool for the RCM teams to go, hey, these are the priority and focus of things that we're going to do to help our patients and you have a better day from an RCM standpoint. Do you have thoughts on this one, Nicole?
This is one of my favorites as well too, because you can really clearly see everything and really how important it is, all these mission critical revenue cycle components. It can't all happen at once. And I can tell you that from firsthand experience. We are in the middle of an implementation with 4 hospitals, 4 of our 12, and it's an end-to-end. Not all of our members will do end-to-end, but these 4 have different arrangements. And, we want to do it right and we want to install it right. And it does take a period of time as displayed.
Good. All right, we're to another poll. And we're going to ask this question twice of you, I think, too, today. So make sure you answer it both. I believe we've got a question at the end of the survey that Becker's is going to ask if you'd like some follow-up from FinThrive. But this one is, based off what Nicole and I have shared on the model, how likely is this something that you'd use at your organization for strategic planning and business? Do you have something like this already that you've kind of built homegrown? Do you feel like this is adding more insights and ease of work in this framework? You don't know yet. You're already done. You can't touch anything now. I'm very interested to understand just where are folks at. I'm excited about this model. I think the RCM TAM is new to the industry. I think it's different than other things we've seen from companies like Crow and I would argue HFMA and others. I think it gets down to, like I said, that granular level. It helps you understand what's critical and mission critical and high value, and then what phase you're in. And it allows that screen that Nicole and I just went over with you, a view into where am I at today? A where's Waldo, if you will, and where do I need to be? And is that our true north? And I think we're going to talk to organizations as we put this model out in the market that are happy where they're at, and that's okay. And it's vendor agnostic too. Not everything FinThrive makes is in there. We make a lot of it, and we'd love for it to be us. But my point is that the model can be applied anywhere. A complete Epic shop that has very little third-party revenue cycle solutions, which is probably losing some revenue, but that might be okay because that's just the edict that's been handed down, all the way up to an organization that feels they are very mature in terms of their KPI benchmark performance and their revenue cycle technology. It still allows you a comparison back to your peers based off their EMR, maybe their phasing, their staging, their bed size, those types of things. That database is going to evolve into that. And that'll allow, I think, folks to understand how they're doing, what they're doing, and where they're going in a much more transparent way. We only got about 20 of you submitting here. So we've got some neutrals. About 70% of you are like, I'm on the fence. Well, hopefully when Nicole and I are done, we can move you to one side or the other, hopefully that positive side. But about 25% of you are saying that you're very likely or likely. And I bet, I don't know how many are on the call, but that probably represents about 50 to 60 of you. If I had to guess, because I know we had about 500 people registered, and I'll bet there's about 200 on the call today. So about 50 of you are saying, hey, we're likely or very likely to probably use this. Those unlikelies, I would love to hear from you. Nicole knows this about me. I love to debate. So let's go grab a drink or some lunch or send me an email afterwards. I'm easy to find on LinkedIn. I would love to have a discussion with you about why you feel you aren't going to use this model, or what you have in its place that would work, or is that a timing, a resource, or a technology thing? Very interested to understand those that are unlikely. Thoughts here, Nicole, on these answers?
No, and I not too many thoughts to speak of, but I think, I am a little surprised on the neutral, and like you said, I hope everybody has some sort of plan.
Yeah.
We went a year. We did strategic planning for a year, and this model that you're describing here just helped us even more. It was after the fact because it's very new, but it would help any entity that's looking at any different vendor.
You bet. I did see a question in the chat about cost. The model's free, gang. That QR code I showed you, and you'll get it in the slides. It's free, and we wanted it that way. We want it to be a thought leadership, tip of the spear in the industry for folks to go fill it out, because as more folks fill it out, the more information that's in there, and the more I think it helps organizations advance their revenue cycle into a new healthcare economy. I think having more folks fill it out and do it is good, and it's free. There isn't any charge or costs, and we don't harass you too much afterwards. I promise, those types of things. We're going to walk in with Nicole here more about just deep dives and what her revenue cycle's doing, and we'll relate those to the model where we can, Nicole. I attest to this statement a lot. If you've seen a revenue cycle, you've seen a revenue cycle. I have the blessing of being able to go to lots of different hospitals and talk to lots of different folks at events, and they are all different. What's nice about that model is it can apply across all of them. And I also think some of the things you and I talked about when we were prepping for this webinar are things that everybody's working on, but you've got a really unique approach in some of your dashboards. And I know one of the things that you're excited about is removing some of the manual reporting that you have to do in all of these Excel spreadsheets and having platform-based analytics from an end-to-end platform that'll help with that. So we'll touch on that as we go forward. But I'm going to hand it back over to you and let you talk through some of your priorities and what you're doing at PMHA.
Great, thanks. As far as our strategic priorities, I put patient experience and satisfaction first on purpose, not money. It is patient experience and satisfaction. We want to make for sure that every patient that chooses our hospitals gets the care that they need, of course, but the experience, and that starts with scheduling. That starts with, making sure that the first person they see in patient access is, pleasantly greeting them. But what I'll wrap in with the technology piece is we wanted, and I'll stick to front and back end. So we wanted it to even happen before they walk in the door. Mm-hmm. So for us, when we were looking at a partner or a vendor, we wanted to see who had anything virtual. What can a patient do on an app before they get there so that it can help them speed them to their service area, as well as maybe they can pay their copay, maybe they can sign some forms before they walk in the door. And that's what we got. That's what we signed up for when we moved with the technology is, we want to know the geofencing, we want to know when a patient gets in our parking lot so that we can prepare for them to walk in the door. And then, patients don't think about revenue cycle, or any of us that work in revenue cycle aside from that and their bill, right? So whatever happens in the middle, they don't care about. So the billing, we want to make sure it's clean so they don't get a bill that they shouldn't have gotten. Maybe we didn't capture the right insurance, just something that takes them away from their day that they have to contact the hospital for. So patient experience above all, number one. Second, cash. We want cash collection. We want to do better at being upfront collection. We want timely payer reimbursements. Sometimes the payer isn't known as our friend, but we need to partner with them. Just like we need to partner with a vendor, we need to partner with the payer to make for sure that they pay us timely, as well as the post-payer adjudication. So what's the patient liability and how do we get that collected from the patient as well? Priorities, reducing AR. We want to get the AR down. You'll see in some of our slides later on the KPIs as we monitor. Reduction in over 90. So we've seen creep. We have seen the over 90 creeping up, and we're doing That is one of our number one priorities, to get that back down and under control. Prevent denials, and that's what when we were looking at technology, we want to stop it before it happens. And it was so hard to manually put all this information together to really deep dive and figure out where was the root cause and how can we stop it. Reduction in bad debt, that comes along with having clean claims and making sure that we have the right information. Holding the payers accountable. This is one of my favorites. And we have a whole division at PMHA that just focuses on contract management and payer relations. And we will hold the payer accountable based on our agreements. Navigating patients' benefits and contracts with their insurance. A lot of times patients will come and it's the hospital's fault. It's the hospital's fault. When really it's their contract that they have with the insurance company. So just getting that awareness out and education. So some of our actual KPIs at PMHA, and again, it's all manual right now, but that's what we're working towards in this implementation, to do away with some of that so we can have more robust reporting, even though this is quite extensive. Currently at PMHA, there's so many, I don't even have a number. I'd say we have about 50 reports that we do a month. We do it by our shared service hospitals, as well as doing a shared service comparison of them all, so that we can keep identifying any trends or issues. So this one in particular is what we currently call tasks now, and we will call them flags as we implement with FinThrive. Really a communication tool. One thing I've had to do in the past, but not currently, is when billers or anybody in revenue cycle have to email departments, they get lost. If it's a clinician, they're treating a patient. So this is a tool that we have where we can communicate with ancillary departments, we can communicate within revenue cycle, and we will just, we trend and track it. It's a little small, but you will see in process is very small monthly, and everything that's been completed or taken care of is in the orange and yellow. Some more KPIs. So this is our weekly receivable indicators, and this is very small. But if you could see on here, our days in AR, our goal is for this particular facility is it's quite low. It's 38 days, and this is a snapshot of the end of our fiscal year where they met the goal. We track this, we trend it, it fluctuates, and that's what we want. We want to, try to curtail in our new system and as we implement. Just a little bit about our structure at PMHA. I always say that we're small but mighty. We have an excellent director combination that goes out, and just to explain how we work in our shared service model is we have directors that work as extension employees within each of our facilities that engage in that service. And then those hospital revenue cycle leaders report directly to the directors at PMHA. And Jonathan had this on an earlier slide. On the right, you will see it's just the revenue management flow from the time of scheduling all the way down through payment, and then revenue recovery and integrity. Budgetary considerations. Everybody's worried about budget. And our hospitals are community-based. They're small hospitals. And as Jonathan said, no one has extra money to put into things like technology. I would say when we were looking through this implementation, talking about the mindset, it's a lot. There's a lot of modules. It's expensive. But I think if it's done the right way, and as Jonathan clearly showed as we talked through the other slides, the return on investment will more than pay for itself. Firm believer, technology is only as good as how you use it. And that's key in all of this, as well as your players. I wanted everybody had to be all in. we had to include the right people and make for sure that this was a alliance approach as well. For cost, we did have a strategy on offsetting some of those setup fees, and that was the insurance discovery product. And what that did is it took our self-pay claims for a period of time and it reran it through FinThrive's TransUnion and would pick up any missed opportunities. We did it for two reasons. So we did want to save the hospital's costs on the setup fees, but we also wanted to know how good our registrars were. And myself and the director of patient access, we were pleasantly surprised that it wasn't a lot of registrar errors. What we found was it was retro Medicaids, and it was something we would have never captured on our own. So it was beneficial in two ways. Any of the revenue recouped, we could offset some of those setup fees, and we'll continue to use that as we go on. Training, it does take, there has to be definite buy-in to put the right training and implementation process in place. Long-term capital expense, that is going to be defined by your return on investment. I talked about the insurance discovery project. Standardization, that's what we do at PMHA, between best practice and standardization. We want to leverage the technology to automate and standardize throughout our members. And then accountability. Just make for sure that the reporting relationships or your senior leadership have buy-in to what you're trying to do. And that's what we did.
Nice.
So
this is a slide. Go ahead, Nicole. On just your general experience. There's a lot of narrative on here, but you can kind of touch on some points just where we're at. And then there's a graph at the end that I'd like to talk about. Go ahead.
Right. So our experience at PMHA, it's the same that everyone is facing throughout the country. We have the low operating margins, we have reduced payer reimbursements, and then the expenses are inflated. We needed to develop and execute a strategic path so that the hospitals could be financially sustainable in the future, and investing in that revenue technology was our strategy. Cost to collect, we need to maximize our investment, so having that solid return on investment is key. And then the RCM TAM, it did afford our organization insights to see where we could gain efficiencies. Like I mentioned in insurance discovery, we were a little skeptical, and it really had some great benefit to the organization. Technology gives us the ability to make necessary changes in process, and that's really what we're looking forward to. How can we get to the root cause, get the clean claims out the door, and the cash collected quicker from the payers? And that's going to be integration of the data, the ability to loop the front end into what happened on the back end, data quality, and the eligibility to our back end payments. And then denials and collections all in one area. Our goal is to make sure our member hospitals get the reimbursement they deserve, no more, no less, just the accurate reimbursement based on the care that we provide in our communities. And that's our goal, and that's what we're striving to do for our members.
Nice. Thanks, Nicole. Those are great, I think, insights as to, one, you're validating that, we're all in this together. I think no one is getting paid what they should get paid from the payers. If you are, let me know. I think everyone's duking it out right now, and I think everyone's having trouble getting staff. I think everyone is struggling at some level with technology that they either have or don't have, or both. And just these things that you've had and put in here, I think, are really shining lights and good beacons, to help people kind of stay grounded in where they're at. And this is that same question that we asked earlier of our customers that have been using some of the FinThrive products, and they had a little bit higher bank of likely or no likely. Now, there was only 13 that had answered then, and we probably had 100 or so answer the other survey, but some neutrals were there as well. I think the profile was about the same as were there. I just thought I'd point that out, that we had our FinThrive advisory board answer that same question about almost 8 months ago, and similar results. What does this all mean? I'm going to finish it up here, and then Nicole and I are going to let you guys have at us with questions. But, I think we need to embrace disruption right now. The visit volumes, like we talked about at the beginning, really aren't going to come back. And I think you've got to capture every last dollar you have. There are new market entrants coming in, retail. I'm sure that's prevalent out in the Pennsylvania and New York market as well, the Walgreens and Walmarts and little clinics and everything. Not that they're wrong. It's just that's impacting the referral base. There's freestanding imaging centers, freestanding surgery centers, and others. And patients are the new payer now. They do have choices in consumerism and others on where they're going. It's very important to not, I like to say, don't mess up the easy part. Don't mess up the billing. The clinical part was the hard part. Try to keep the easy part as frictionless as you can as they're there. Self-service, I think, is the key, especially with the millennial generation coming on board. I think they represent one of the largest segments of the population. Cash their checks, access their bank accounts, pay for their food bills, ride in vehicles, are all on their phone. And they all want to access their healthcare, pay for their healthcare, get the results that way. And having technology enables that. Platforms are important. Nicole shared with you how this is the quickest path to restoring profitability. She's got very clear KPIs that you saw, where she's at, where she needs to be. I would argue she's already at best practice in many of the categories, but I loved hearing from her. That's still not good enough. We want to be best of the best of the best and continue to move on our own numbers as we proceed, and having a platform was a key in that decision. This model introduces a peer-reviewed, data-driven approach to modernizing your revenue cycle. I encourage you to go look at it. We'll put that slide back up maybe at the end that shows you how you can go access it. I saw some questions in there. I think it was slide 20. If you don't have the deck, we'll make sure we get it to you. But we're going to turn it back over to you, Erica and Becky, and any other for Nicole and I to answer some questions here in the last 7 to 10 minutes.
Wonderful. Thank you so much, John and Nicole. What an awesome presentation and so engaging, which I think is shown in how many questions we've gotten in our Q&A box already. So I'll dive right into those. And if folks want to continue submitting questions, please do. We'll see how many we can get through in the next 6 minutes. No pressure, John and Nicole. All right. So the first question that we'll touch on, I think, John, maybe you can tackle this one first, but I'm sure Nicole will have some great insights here. This one's about transformation. So from a transformation standpoint, how does this model account for other elements like management and workforce competency, as well as state of business practices?
What an awesome question. Whoever that was, that's brilliant. That's the model's evolving to that. We've had one of our customers who's gone through the model. They have some of our solutions, but not all. And they had asked, hey, how does this impact my staffing and productivity levels? And we're going to add that in, I think, as one element. So, hey, a phase 5 may have, this level of FTEs, which theoretically, and I think this will be the case, there should be less FTEs having to touch keyboards in a mature stage 5 organization than a stage 1, for example. But what is that incrementally? The same goes with, hey, what is the level of IT resources? That may be inverse to that type of discussion in terms of just, I think you're going to need more IT involvement the more mature you are, and there might be more investments as well in terms of people, process, and technology, but having more things hooked in. All of that, though, with the platform, as Nicole can share, is certainly easier because it's one pipe that has analytics across it that allows longitudinal claim analysis, I like to call it, to where you're seeing what happened to eligibility that might cause a claim payment that may have been related to the contract that ultimately impacted a denial and how much cash was posted. Very hard to have that conversation outside of a platform. Great question.
Thank you so much, John.
I agree, John. Really, it's looping it all together, and that is gonna affect productivity in a positive way.
Yeah.
Okay, wonderful. Well, next question is, does it calculate net receivable? So this tool that we've been discussing, Does it calculate net receivable? And then I think we might be able to tack on another part of this question, which is, what does the tool run on? Is there a particular platform?
Yeah, I can handle, I think, both of those. Net receivable is an attestation right now that the customer would put in there when they fill it out, or a hospital. So there's a question in there that will ask, what are your receivables in terms of days right now, and your AR over 90, like you saw on that slide that Nicole shared. And then that will, be compared to where other hospitals and health systems in your phase would be. Every hospital calculates AR days differently. I call it the balloon or revenue cycle. You can squeeze AR and it'll spit out cash or denials the other way. You can make your AR number look however you want by quickly writing off things tonight and do that. So that's understood. We are at FinThrive technologically, through our customer success and innovation teams, taking data that we have in the platform and applying baseline metrics now and reporting. We're going to start reporting that back to customers and going, hey, this is what we think your AR days are and what they should be based off of metrics that are already within the platform. That's the next evolution. This tool will assess based off attestations if we're there, but that's that one. The other question, Erica, can you repeat the little back half that you wanted to tag on?
Sure. So the question was asking about the platform that the tool runs on.
Oh yeah. So the assessment really is just a survey. So it's on the web. You'll go fill it out, and it takes the results and puts them back to us into a database that we're taking into Power BI, Microsoft Power BI, and actually being able to show you that view that we saw of, how many hospitals have an Epic platform versus an Oracle Cerner versus Meditech versus Allscripts, with their bed size NPR. And like I said, hopefully we'll be able to start filtering it down, and I know we will, to stage 3 versus stage 2, financial evaluation of one versus the other. But that database will be in Power BI, which is pretty familiar, and I think most folks will be able to start to see some of the results from that as we evolve the solution out.
Wonderful. Thank you so much, John. And I think we have time for one more question. I wanted to make sure we ask this question just so we can hear from Nicole again as well. Sure. Nicole, is there any way that you can share your business case?
Sure. As far as with the end-to-end solution?
Yeah. I mean, I know it's probably a complex question, but any highlights from that would be helpful for our listeners to hear.
Sure. I think, the business case was we knew we needed a company partner that was investing in technology. So, that was number one. And we included the players within each of the organizations within our governing platform of our task force that we had put together. With that, keeping everyone in the loop, especially the senior leadership at the hospitals, as we went through and looked at pricing, we went and we worked as a team on premier pricing. So it was new to FinThrive as well, because we have 12 hospitals, not going up at one time. So being able to show the hospitals how we worked through the pricing to get everybody really the best pricing that was possible for what I consider the best of the best out there. So, we just talked through, made sure we met, we included everyone at all different intervals within the facility as well.
Great. Eric, I think we're probably at time, but I saw in the comments that folks were looking for the QR code. That's there. If your phone's not working or the QR doesn't work, you can also go to finthrive.com and search on adoption model, or use Dr. Google. You'll find it that way. If you do FinThrive adoption model, I believe you'll go to the same link, and then there's a little page there that gets your name and your email, and then you could get launched over to the survey and start helping us help you and the industry. That was all I think Nicole and I had. Erica, we'll turn it back to you.
Perfect. Thank you, John. And thanks for having that slide pulled up. I know a lot of folks were asking for that QR code, so hopefully that helps. So once again, I'd like to thank our wonderful speakers today, and also, of course, FinThrive for sponsoring the webinar.
Thanks, everyone.
Thank you.